DKA versus HHS, NCLEX and nursing study notes. Hyperglycemic emergencies. Both diabetic ketoacidosis DKA and hyperosmolar hyperglycemic state HHS are life-threatening hyperglycemic emergencies, but they differ in cause, laboratory findings, clinical presentation, and treatment priorities. Diabetic ketoacidosis definition: Diabetic ketoacidosis is an acute metabolic emergency caused by absolute insulin deficiency resulting in hyperglycemia, ketosis, and metabolic acidosis. Common patient: usually type 1 diabetes mellitus, can occur in type 2 diabetes during severe stress. Pathophysiology: no insulin available, cells cannot use glucose, body breaks down fat for energy, fat metabolism produce ketone bodies, ketones cause metabolic acidosis. DKA mnemonic: CUSS. C. Ketones elevated in blood and urine. U. Urine output increased osmotic diuresis. S. Sugar blood glucose 250 to 500 milligram per deciliter. S. Serum pH less than 7.3 metabolic acidosis. Clinical features: Kussmaul respiration, deep rapid breathing, fruity acetone breath, nausea and vomiting, abdominal pain, polyuria, dehydration, altered mental status, severe cases. Common triggers: missed insulin doses, infection, surgery, severe illness, newly diagnosed type 1 diabetes. Hyperosmolar hyperglycemic state HHS definition: HHS is a severe hyperglycemic emergency characterized by extreme hyperglycemia, hyperosmolarity, and severe dehydration without significant ketosis. Common patient: usually type 2 diabetes mellitus, most common in older adults. Pathophysiology: some insulin is present, ketone production is prevented, blood glucose becomes extremely high, severe osmotic diuresis develops. Profound dehydration and neurological impairment can occur. HHS mnemonic: HOG. H. Hyperglycemia, blood glucose greater than 600 milligram per deciliter may exceed 1000 milligram per deciliter. O. Osmolarity, serum osmolarity 320 milliosmolarity per kg. G. Gradual onset, develops over days to weeks. G. Glucose cause severe dehydration. Clinical features: severe dehydration, hypotension, confusion, seizures, coma, no Kussmaul respiration, no fruity breath, normal or near normal pH, higher mortality than DKA. Common triggers: infection, acute illness, poor fluid intake, older adults with type 2 diabetes. Nursing priorities: both DKA and HHS. 1. IV fluids first priority. Restore circulating volume. Begin with 0.9% normal saline. Insulin therapy: use IV regular insulin. In HHS, start insulin after initial fluid resuscitation. Important NCLEX point: do not start insulin before fluids. Monitor potassium. Insulin drives glucose and potassium into cells, lowering serum potassium. Check potassium before insulin therapy. If potassium less than 3.5 milliequivalent per liter, hold insulin. Replace potassium first. Treat the underlying causes. Example: infection, missed insulin, surgery, acute illness. Continuous monitoring. Monitor neurological status, urine output, blood glucose, electrolytes, vital signs. A patient with NCLEX tips: a patient with type 1 diabetes plus ketones plus metabolic acidosis plus fruity breath plus Kussmaul respiration equal to DKA. A patient with type 2 diabetes plus glucose greater than 600 milligram per deciliter plus severe dehydration plus confusion plus normal pH equal to HHS. Do not diagnose DKA based only on high blood glucose. Always check ketones and blood pH. Always assess potassium before administering insulin. Normal saline is the first treatment for both DKA and HHS. DKA, CUSS, ketones urine output increase is sugar 250 to 500 milligram per deciliter, serum pH less than 7.3, HHS, HOG, H hyperglycemia greater than 600 milligram per deciliter, O osmolarity greater than 320 milliosmolarity per kg, G gradual onset, G glucose cause severe dehydration. Golden NCLEX rule: first sweet first, check potassium, then give IV insulin.